Hello, I'm Neal Kassell, the chairman of the Focused Ultrasound Foundation. This is Parkinson's Disease Awareness Month, and accordingly, we thought we would take this opportunity to provide an update on the role of focused ultrasound in treating Parkinson's disease. So, focused ultrasound is a non-invasive, game-changing alternative to surgery for treating the symptoms of Parkinson's disease. But even in the future, it holds the possibility for holding the progression of the neurological deficits or even reversing the neurological deficits and restoring function in certain patients. So to discuss this topic, we're joined by two of the world's leading experts in Parkinson's disease. Paul Fishman, who's the professor of neurology at the University of Maryland, and Jose Obeso, who's a professor of neurology at CEU San Pablo University and the director of the Neuroscience Center, SINAC, in Madrid. Both of my colleagues have extensive experience treating patients with Parkinson's disease, but they both have active research programs both at the laboratory and the clinical level on focused ultrasound as well as other treatments for Parkinson's disease. So let's get started. So my first question to Jose is, Parkinson's disease is not one disease, it's a family of diseases. Could you tell us a little bit about that?
Thank you, Neil. There are different ways where one can approach how to dissect out clinically Parkinson's disease. And the three main features or factors, in my view, are age of onset, clinical presentation, and the state or stage of evolution of the patients. The age has a major impact because the older the patient, the more general the symptoms and clinical features are, and the more overt and important are the non-motor manifestations like speech, sphincter problems, cognition difficulties leading to dementia, falling, equilibrium, etc. So the older, the less classic motor features are predominant in Parkinson's disease. And that occurs typically in people who are above 72, 75. Much younger individuals are much more pure, inverted comma, motorically, and much more focal. And then it comes the second factor, which is for those who are much more motor, and the classic Dr. James Parkinson description, fitting that classic description, those people who are more than half of the patients in presentation can be divided according with tremor dominant or non-tremor dominant. The tremor dominant are typically unilateral, very focal, a hand shaking, a foot shaking, and the evolution of those patients typically is slower, more benign, easier to manage for many, many years, accepting the fact that tremor is somewhat less responsive to typical drugs, typical anti-Parkinsonian drugs like levodopa, and those form the basis for one of the best indications of focused ultrasound currently. And then we have what evolutionary stage they are after let's say 5-7 years of evolution. In those early years, patients are early. Then between 7 and 15 is like intermediate middle evolution, and then advanced evolution, because the longer disease evolution, the more severe and more widespread the clinical features are, and more complex. And of course, the older the patient is, and therefore the combination of longer disease and older age combine again to produce this plethora of non-motor manifestation I was alluding earlier on.
Terrific. Now, Paul, can you tell us how focused ultrasound can be used to treat patients in these different categories?
The most straightforward group of patients to apply focused ultrasound, and where it has regulatory approval in most places in the world, are that group of patients Jose talked about, where tremor is their most problematic symptom. And for these patients, really springboarding from the original brain approvals of essential tremor, and actually the same surgical target. So for patients for whom medication does not significantly functionally improve the tremor, focused ultrasound is a very reasonable alternative uh, for significant improvement and reduction in tremor in those patients. The things that are now evolving throughout the world are following the same path of those patients who currently are treated with deep brain stimulation. And the largest group of those are patients for whom their medications relieve their symptoms, but relieve their symptoms unpredictably erratically. They have what are referred to as dose fluctuations, where their symptoms can appear even a short time after they've taken the medications, or the medications, particularly the levodopa, will wear off quickly. Some of the patients will develop a form of hypersensitivity to levodopa, where they develop abnormal movements from their levodopa. And these are patients who have been approached with surgery for several decades. And what's evolving is now using this non-incisional technique as an internal alternative to deep brain stimulation for patients with Parkinson's disease who have fluctuating responses to medication and who have a response to medication that causes the interference of involuntary movements on top of voluntary movements. And those are the two areas where things are closest to and working toward regulatory approval.
Jose, do you want to amplify a bit on the
Right.
topic of the motor symptoms of Parkinson's disease, or even the cognitive deficits?
Right. Well, I agree with Paul. Clearly, those are straightforward. Let's stress that in PD and historically from ablations with radio frequency and then DBS, the two primary targets had been the globus pallidus pars interna and the subthalamic nucleus. The VIM in the thalamus was quickly abandoned as not the preferable target. So the fact that now most of the centers using focused ultrasound are doing thalamotomy just reflects that this is easier to begin with, is much more doable, approachable, and the results are typically very good. However, when treating PD, one should rather think in the GPI, pallidus, globus pallidus pars interna, and the subthalamic nucleus. And the subthalamic nucleus is, I think, without any question, the most pivotal not nucleus in the Parkinson motor network. And the approaching and modifying abnormal neuronal activity in the subthalamic nucleus is what really has modified the evolution of Parkinson's disease. My personal understanding and belief is that we should not allow patients to get to that stage when motor complications that Paul was referring to becomes very overt, very complex, and difficult to manage. I think the beauty of focused ultrasound is that eventually, soon, today in my team, allows us to attack, to impinge upon the subthalamic nucleus unilaterally, because patients in the first 5-7 years are still quite asymmetrical, by and large, if they are not too old, and then get the motor cardinal feature metrical, and therefore in of those high proportion of patients for quite a considerable time, long period. And then when the other becomes more symptomatically, then we can decide what to do. We have done already bilateral subthalamotomy, of course, a stage, never at the same time, with a year and a half in between lesioning, and do remarkably well, and no catastrophic, in fact, no severe side effect occur. So I think this is where the future is, because this is the most potent, almost a therapeutic active target in the basal ganglia for Parkinson's disease.
Good.
I know this is still I'm happy to to concede that.
Paul, let's talk in terms of technology a bit. How does focused ultrasound work for Parkinson's disease?
Well, the biggest technical obstacle that it really took decades to work out is getting sound energy through the skull. It really uses the same general principle that radiation-based surgery at gamma knife roots, and that is to use an array. Lots and lots of sound energy is absorbed by the skull, and we want to get it into brain to the point where we can get enough energy to heat brain to a point that we can actually lesion or destroy a small spot of tissue for that. And that's done by having a helmet really that is on the patient's head that has an array of over 1,000 separate emitters of sound energy. And they are engineered to be focusable so that all that sound energy concentrates at a point. And each one of those emitters has very little energy. So there's very little to no damage or heating of brain on its way to the path. They're designed to all converge on the path. And again, 1,000 times that energy is enough to heat brain to lethal temperatures. And so what we're looking for is to destroy a overactive abnormal area of brain in a very precise way so that that heat energy does not spread out and damage neighboring brain areas. And again, what it shares with deep brain stimulation is that patients are part of the team. It's done awake, that reduction in tremor and making sure that the patients don't develop any side effects from injuring brain area close to the target. And that varies for each form of target. Sometimes patients can develop some numbness, patients could develop weakness. And in the target that, and Jose's group has been incredibly precise in targeting the subthalamic nucleus, where many investigators were very reluctant to do this because if that lesion gets too large, which can happen sometimes in the case of even a small stroke, one can unleash dramatic abnormal movements, which haven't happened in the very precise lesions that have been made by Jose's group. And so again, it's the fact that you have a computer-controlled focusable array, and the other aspect is MRI. The operator never really truly sees the target. He sees an image of that target on MRI, and MRI not only gives us an image of brain, but superimposed on that is a temperature map that looks pretty much like a weather map that you see on the news, where you can see brain temperature on a millimeter basis, and then the computer can really predict how much energy we apply to brain, what the brain temperature will be. It's quite, we can monitor that, and so that we can create an area of brain that has been heated to cause a permanent lesion, sparing areas of brain around it. So again, it really is a matter of the computer engineering of the array, MRI that can give us an accurate target. Special sequences of MRI are now used that can really give us a very clear picture of the fibropaths as well as the cellular areas that we wish to lesion, superimposed on MRI thermography, telling us the temperature the amount of heat and energy that we're depositing in that so that we can create a controlled lesion that really has not been possible in some of the earlier surgical procedures.
Yeah, that is exactly the case. I like to add that I mean, this is still a methodology with a lot of room for improvement. This is work in progress, and so I think people interested in the approach, both colleagues and patients, do have to understand that you know, if we see the difficulties, side effects, and failures that we had and we reported in the 1996 to 2000 with the beginning of DBS for Parkinson's disease, the complications and the rate of failures there was much worse than what we are collectively having today with HIFU. So I think the starting has been good, but there's room for improvement. One of the features, I don't know, Paul, what you think about this. One of the features that I would like very much to see improved is that as the lesion is growing, one could model the thermal map to adapt it to the target. Currently, essentially, the machine decides how the lesion is going to be implemented and how it's growing. And in many occasions, the thermal map grows and develops at least in one of the three planes of the space, not in the right direction. It goes opposite of the right direction, and that is you know, oblige us to be extra careful to recenter the lesion mass of gravity where we want it. So and to be able to model that for each patient before starting, and then to watch as this develops, I think would be a major adventure. Say it could be an adventure, but a major development for improving the characteristic according with the clinical characteristic of each patient, and to really get much better clinical benefits against motor features and eventually against some non-motor features, and further to apply and extend HIFU beyond Parkinson's disease to other conditions. And we don't have that currently.
You know, patients often ask, what is the success rate and what are the complications of focused ultrasound?
Well, I would say that, again, it depends on its application. For tremor, what we're talking about, and even for motor symptoms of Parkinson's, I think a reasonable round figure is to say about 50% reduction of symptoms in the off state. With tremor, it can be even greater. So again, if average, there are going to be some failures, but on average, and that is close to comparable to that of deep brain stimulation, that off period symptoms are reduced between a third and a half. Tremor, probably a good deal, a bit more than that, between a half and 2/3. Complications, serious complications are rare. Serious complications that actually can be disabling are in the same ballpark, and actually less frequent that happen with deep brain stimulation are in the order of 1 out of 100. Minor complications are common, and that can include slight weakness, slight numbness, some degree of imbalance, some worsening of abnormal movements. And again, we're talking about those patients, in 80 to 90% of them, they're short-term and they're mild. So again, I would say it really depends on the indication, the surgical target, and as Dr. Obeso mentioned, for Parkinson's disease, there are at least 3 and perhaps even 4 different surgical targets in the same general area of the basal ganglia, targeting to specific symptoms. And so the side effect profile is really related in a lot of ways to location. There was a great deal in the target that we've been looking at in the older surgical literature, the globus pallidus interna. The older surgical literature had said that one can impair the visual pathways and get actually a field cut. That was common with open surgery, but is really not occurred at all in focused ultrasound. So again, side effects depend on what brain location that you're targeting. And the fact that, as Jose mentioned, the accuracy of targeting, and again, that is an area for growth. The area for growth not only is using better thermal mapping, and it really is that thermal dose to a piece of tissue is what determines whether or not that piece of tissue is only injured or killed. And so the thermal map that Jose was talking about is vital. It relates to the treatment failures, and occasionally what we see, probably less than 1 out of 10, is a patient where their symptoms are relieved during the procedure, but we've injured that tissue and not killed it. And so over the next few days or weeks, that tissue can recover. So what we want to do is permanently kill the target tissue, but what we don't want is having that thermal area extend nearby, because if we're going to have a side effect like weakness, like numbness, we want to be confident that that's going to be mild and transient. We don't want that area to now enlarge after the treatment is done. And again, the accurate thermal mapping, that calculation of thermal dose is important. The other thing that is in the future is developing techniques to look at brain physiology during the procedure. One of the biggest differences between this and deep brain stimulation is that deep brain stimulation does a form of brain mapping with microelectrode recording to confirm the target. And that's obviously in a non-invasive technique where no probe goes into it. That's not possible. But through forms of imaging, functional MRI, there's clearly an interest to develop a better way of physiologically identifying the target besides looking for changes in symptoms.
Yeah.
In patients, go ahead. I'm sorry, go ahead, Jose.
No, sorry, just to highlight the latter, because I think this is how this particular area is going to, one of the very good aspects where it is going to develop because of brain imaging and functional MRI. For instance, for the subthalamic nucleus in my team, Rafael Rodriguez Rojas has characterized the cortical subthalamic connectivity and divided the motor region of the subthalamic nucleus, the associative, etc. And within the motor region, separate the lower limb from the upper limb and the primary motor cortex from the supplementary motor area, which is amazing for giving a relatively smaller structure. And we can map that out now, but of course, before the treatment started, not during the treatment. And that's why I think this is the important next step, that we could know where the upper limb and the primary motor cortex region is for the GPI, STN, etc. We could then target that particular region for a given patient. And when that happens, the percentage of accuracy of benefit will improve, and the side effect will be reduced.
In patients in whom the symptoms return after treatment, either because the treatment has failed or because the disease has progressed, can they be retreated? Jose.
Yes, certainly. Certainly. Is a failure is a typical one that Dr. Fishman was mentioning, that it's just that the lesion was either not perfectly targeted, the lesion was not large enough, or the target was not perfectly placed. This is one of the advantages of HIFU, that is much easier to do a second treatment, that when that happened with an electrode, or all the time when we did radio frequency, that of course we were not going back to the OR to do another burr hole and repeat the procedure. So this is one of the advantages of HIFU, without any question. Mind you, for Parkinson's tremor, my hunch, and I'll be interested to know what Paul's experience is, our experience is that recurrence for essential tremor patients is low. It's lower than 10% in our hands, whereas recurrence for Parkinson's disease tremor is used to be higher at the beginning of our hands. Now we have improved it, but it seems like the Parkinsonian tremor has a higher propensity to return after a few weeks or months, even when the initial lesion appears to be all right.
Yeah, that actually has been our experience as well. A Parkinsonian tremor is really more complex in physiology than essential tremor. And a lot of literature suggests that there's more than one tract that's involving it. And so again, we had some experiences with early recurrence as well. And then this idea that, and sometimes even it's been an experience with DBS. In the OR with DBS, you think you have it perfectly placed, and then you're almost ready to say, okay, we're done. And then the tremor comes back unexpectedly. So it's a very much more unpredictable tremor, and very likely has a second pathway that's superior to the first, to the typical essential tremor that probably needs to be treated as well. So again, it's it's one of those things. I'm happy that that Jose also reports this idea that of evolving experience. As we get more experience with this technique, I think it's pretty much been uniform in all centers that their results improve with time.
Another question, which patients are optimal candidates for focused ultrasound, and which patients are not candidates for focused ultrasound? Jose?
Right. Well, the non-optimal candidates are the ones who are not optimal for DVS either, because they have developed far too many non-motor complications, particularly dementia or dysarthria or sphincter problems and gait and instability, etc. That typically occurs after long-term evolution. I would not advise either of focused ultrasound currently for people who are excellent candidates for DVS, who are those Paul Fishman was mentioning earlier on. That means patients who have developed severe motor fluctuations on off, severe dyskinesias, etc. I think those should go straight into DVS or a infusion therapy. I think we like to treat, there are a number of patients, certainly anybody who has severe dyskinesias who are particularly asymmetrical makes a tremendous benefit, a pallidotomy that Dr. Fishman group is a well leader. But we have done a number of them, and they work exactly as good as they used to be with radio frequency. But those are not very many in our hands anymore. Then a patient who are asymmetrical, tremor dominant, can have a thalamotomy and they will do very well. If they have tremor or akinetic rigid features, but are still asymmetrical enough, which in our hands occurs in about 20%, 30% of our referral patients below 60 year old. So those are very good. And in those cases, and very specific to our interest, we would do a subthalamotomy, not a thalamotomy. But if the tremor is very, very severe, we may be conservative and go for a thalamotomy just to make sure that the tremor will be improved. So I would say people who are still essentially motoric, and if asymmetrical, all the better.
Paul, do you have anything to add to that?
Yeah, I think sometimes these things are not black and white, particularly in the older patient population, where patients can have significant motor symptoms, and they do have some degree of mild dementia. And these have always been difficult patients to decide whether or not they would benefit from deep brain stimulation, because there actually is some literature that suggests that deep brain stimulation might actually worsen the long-term prognosis and the worst, particularly cognition. One of the things we're looking at in terms of our data right now, and it's been argued with deep brain stimulation, is whether or not the physical probe that penetrates the frontal lobes, the subfrontal cortical white matter, and other areas of the basal ganglia, whether or not that physical probe contributes to cognitive loss in these marginal patients. And we're currently looking at it, and I'm sure Jose has data as well. All of the patients in experimental studies that we've done have undergone intensive pre and post cognitive studies. And at this time right now, we're analyzing it, but the question is whether or not this incisionless technique that destroys a target but has no effect on brain between skull and target is more friendly to cognition than deep brain stimulation. And again, I'm sure Jose may have data as well, since it's common practice in experimental studies to look intensively at patients' cognition, because as Jose will talk about later, in the later stages of Parkinson's, it's cognitive loss and gait and imbalance that are the most disabling features of the disease. And Jose's involved right now in studies looking at Parkinson's disease dementia with focused ultrasound in a non-ablative strategy.
Yeah, that's a different thing. We know that the focal unilateral ablation does not produce cognitive impairment. Now, the question that Dr. Fishman is posing is, if I understand it correctly, is a little bit different, because we do a screen out for cognitive impairment, and we try to avoid people with cognitive, even if it's mild cognitive impairment, we try to avoid those. But you're right, Paul, that this is highly prevalent, particularly in the older population. So that's a good question, because they are not going to have surgery. They may be also limited in terms of the medication, the dosing of anti-Parkinsonian drugs. And so if we can improve them, even if in a limited fashion, but still improve and get rid of bothersome dyskinesias or a annoying tremor, I think that can be helpful, but that would be worthy a study, because it would certainly offer a therapeutic opportunity to a proportion of people who are now getting almost locked out.
Jose, now that we're talking about cognitive changes, do you want to comment on what you see the role of focused ultrasound is in the future in treating patients where cognitive changes are predominant?
Right. Yeah. Thank you. The opening of the blood-brain barrier with low intensity focused ultrasound is a kind of blooming area of neuroscience. It's easy to understand. It's easy to convey. My patients and sponsors, donors understand it. It reminds me a little bit the stem cells hype decades ago. Everybody becomes interested in this. The area needs a lot of development yet, and we are facing and trying to resolve obstacles with the technique. We apply this to a number of patients with Parkinson's dementia just because the initial studies came from the Alzheimer's amyloid model in the mice, and the Alzheimer's community has quickly picked up on this and has started studies doing blood-brain barrier opening in Alzheimer's disease, also in ALS patients, because obviously they have no therapy. So we decided to start with a number of patients with Parkinson's dementia, and we just, like it was reported for Alzheimer's, it turned out that the procedure is feasible and is safe. And we opened at the parietal occipital temporal junction, because that's where levy body inclusions is very abundant, if not the most abundant, in patients with PD dementia, also in the and in the striatum. So we are now doing BBB opening in the putamen in patients with PD and mild cognitive impairment, because amyloid deposits are frequent there, and the mice had amyloid overexpression, and the BBB opening reduced by half the amyloid load. So we thought, well, maybe this is a better focus. And in any case, we want to target the putamen, okay, eventually. So I think this has two different tech scenarios. The cognitive impairment, which in Parkinson's disease, we should aim to treat the degeneration before dementia occurs. And we have the privilege there that we can detect mild cognitive impairment early in evolution, and then this would be the moment to act. Of course, anybody, and I guess our chairman will quickly ask, what are you going to do? Because obviously the opening is not good enough. And this is a real question. But one can envisage and dream with antibodies, with anti-inflammatory, with restorative therapies, gene therapy, etc. Now, to be honest, my real dream is not that mainly. My real dream is to be able to detect Parkinson's disease very, very early. If it is a form which happens, we get evidence that it happens to be evolving from the periphery to the substantia nigra, let's attack it with BBB opening and delivering molecules that stop the degeneration earlier. If it is the more common situation where nigrostriatal dopamine degeneration is occurring and is driving the process, we could detect this very early when it's really focal in the caudal putamen and deliver there by BBB opening molecules or therapies that will restore the deficit and will halt or slow down disease progression. That's what I really would like to be happening in the near future, and that's what we work for. But well, still a long way to go.
Well, I don't know if we're that far away, because there's one very interesting clinical trial of blood-brain barrier opening going on that just began in Canada with Neal Kassell. And I agree, I share the same dream with Jose. Matter of fact, my dreams are even a little more grandiose, which is even I dream of reversing symptoms, that not just stopping them. And so we know that certainly even in mid-stage Parkinson's, there's still a fair number of cells left. They're capable of growing, they're capable of branching. And in spite of all of the failures of the many, many clinical trials of disease-modifying therapy, many of them may have failed because they did not cross the blood-brain barrier. And right now, there's a very interesting trial that Neal Kassell is leading, using a combination of blood-brain barrier opening and an available neurotherapeutic. So there's a clear link genetically between Gaucher's disease and Parkinson's disease. And for patients who are relatives of patients with Gaucher's disease who carry a single copy of that gene, they have a several-fold increase of Parkinson's disease. And there have been a lot of experimental studies that say that this enzyme that's defective in Gaucher's is involved in the development of pathology even in patients who have normal genetics. And what's interesting, in general, from a regulatory point of view, it's very difficult to test both an experimental substance and an experimental technique, like opening the blood-brain barrier. Neal Lipson's group has kind of avoided that regulatory barrier in the sense that for patients who have Gaucher's disease, they've been benefited by enzyme therapy, which has been FDA approved for decades. And the problem with that is that, again, that enzyme is too large to cross the blood-brain barrier. And they've been treating a small number of patients with this approved enzyme and with the experimental opening of the blood-brain barrier. And so they're going to look to see, similar to Jose's trial, can they do it safely? Can the enzyme, how much the enzyme is going to get into the brain? And then, of course, the issue of, is it going to have any impact on clinical symptoms or development of it? And so when it comes to what you can deliver, we live in now the molecular genetic age. If we can decide on what on earth would be beneficial to Parkinson's patients, our colleagues who are molecular biologists can probably engineer the molecule. And now we have an experimental tool, an additional experimental tool to help get that into brain. So it's really great to see these, like Jose's study, to show safety first. And then just, is there benefit to opening the blood-brain barrier in Parkinson's, dementia, and Alzheimer's disease? Is there clearance of these abnormal proteins out of brain? And then the second step, what would be the most beneficial agent to try to deliver? And I think that's where the future is.
Yeah, this is precisely the case. Being a little bit, realistic, this is the way I think it will happen. If Focus Ultrasound Foundation is certainly facilitating all that process. But as I said, this is easy to understand, easy to convey. Reality, as typically is the case, is more complex. For instance, we have done an initial study delivering a viral vector in monkey models, and the vector do get through the opening, and the neurons pick it up and express it, but express it in a limited fashion, not one that we could be thinking is going to be hugely therapeutic. So that, for instance, has many factors, because you have, and let alone the fact that an animal is a healthy animal, which is being, denervated or whatever experimentally, while our patients are older. Some of them, or many of them, have comorbidity. The striatum is full of virtual rovings spaces. They become dilated with the blood-brain barrier opening, etc. So a lot of things going on there, which I think one doesn't anticipate with the initial approach. That we need to learn about this, but it will happen. I mean, the technique is great, and it offers a lot of opportunities. I completely agree.
Well, I think the audience that is watching this video can sense your enthusiasm and excitement about the future. Do you have any additional comments about where you think the field is going in the next several years?
My personal understanding is that in Parkinson's, we go for earlier recognition. And already we know that the earlier we treat patients carefully, the better they do. The patients Paul Fishman and I used to deal with 20, 25 years ago are now a rarity. So patients do evolve better, but we have to battle the neurodegeneration progression plus aging, because people now currently age with Parkinson's disease. It's the first neurodegeneration where the two processes, aging plus neurodegeneration, occurred together and occurred together for decades, not just a few years, a long time. And that implies a new challenge and a new situation. But unquestionably, earlier recognition, earlier treatment, and just to finish, I think we'll be treating patients symptomatically to recover the motor circuit very early, and we should be delivering a cocktail kind of molecule, like it has happened in cancer and in viral diseases, to treat the disorder, because it's multi-etiological. Even in genetic forms, the mechanisms are multiple, and we'll need to apply a cocktail of molecules to actually tackle and make a dent. But we're getting closer.
Paul?
Well, I think as Jose already illustrated, sometimes we need a change in treatment. Again, traditional approaches don't like drug cocktails. Matter of fact, that's why they have kind of that nasty name. And again, combination of therapy. And Jose's exactly right about the limitations of blood-brain barrier, but focused ultrasound is only one technique that can be combined with others. There are focused ultrasound investigators who are looking at nanoparticles, who are looking at different forms of viral vectors that are more capable of spreading within the nervous system. So it's not going to be, none of us aspire to be one-trick ponies. We want to be able to combine any of these techniques that are going to help move the field forward and are going to benefit our patients. And having focused ultrasound as one of the options, focused ultrasound isn't going to replace DBS, but it's going to give patients other options. And we're going to talk about multiple targets. I foresee a time where we sit down with patients and go through all the options and match whether patients early onset, late onset, what aspect of their treatment we're going to apply to.
Well, this has been a fascinating conversation. It's been said that the best way to predict the future is to invent it. And we thank both of you as pioneers who are driving this field forward to the benefit of many, many patients with Parkinson's disease. And for additional information, we encourage people to go to the Foundation's website. Thank you both for all of your time. Thank you for all you're doing for the field.
Well, thank you for inviting us, and thank you, Neal and the Foundation, for their leadership and support in this field, helping making all the things we do happen. Thank you.
Absolutely. I echo every word. Thanks a lot.
Okay.